56-year-old lady presented with obstructive jaundice with ampullary carcinoma where Pylorus preserving pancreatico done. Mid-clavicular port is used to decompress the grossly distended gallbladder. Then transverse colon hepatic flexure mobilized well down for exposing the duodenum and the head of pancreas. The peritoneum is being incised using harmonic ultrascision. Then head of pancreas cauterized and IVC in the vena cava has been fully exposed. Cauterization done up to the aorta. This is second part of duodenum, junction with third part. And while dissecting the second and third part, we could reach the root of mesentery. This is reaching the upper pole, and coming down, the uncinate process is being dissected from the supramesenteric pedicule. The uncinate process is being separated, and right gastroeploic vessels are ligated with silk. Supramesenteric artery in the right gastroeploic artery and vein are divided with right gastroduodenal artery dissected, ligated proximal and distally and divided close to its origin from the common hepatic artery. Common bile duct is dissected circumferentially with used curved dissector, and choledochotomy was done and the complete bile aspirated and the duct decompressed. With a carefully dissected from the portal vein, common bile duct is divided circumferentially using harmonic scalpel. After division, a loop of ligature is applied to the proximal end to prevent biliary leakage during the procedure. A loop of silk ligature applied to the duodenum part 1 then divided with harmonic distal to the pylorus. Another loop is applied to the gastric side to prevent the gastric juice leakage. Next phase comes the mobilization of the duodenojejunal flexure by dividing the ligament of Treats. Two ligatures applied to the jejunum and divided in between, and the jejunum is taken to the supracolic compartment. Further mobilization of the neck of pancreas from the portal vein and superior mesenteric vein. Tributaries are clipped and divided. The head is totally free, only the attachment with the neck is there. Gastrocolic vein, which is seen, is being ligated with silk. Before division of the neck of the pancreas, we take 2 stitches in the inferior and the superior border to minimize the bleeding from the divided end of the pancreas. This inferior border ligature, now we are taking bite at the superior border of the pancreas. Now the neck of pancreas is divided And it is final division of the neck of pancreas with ultrascision. There is no bleeding. Now the specimen is totally free. The divided end of the pancreas, the pancreatic duct, is visualized. The specimen is placed in a bag, endo bag, and extracted through a mini laparotomy by 4 centimeters in the epigastrium. Jejunum is brought out, edge is trimmed, and the gastro end to side, gastrojejunectomy is done extracorporeally. We place 2 stents in the jejunum, one for the pancreatic duct, another for the jejunal decompression. The loop is taken to the supracolic compartment through the mesocolon by creating a window. Now the common bile duct is trimmed, and the end of common bile duct is anastomosed to the enterotomy already of the jejunum side. The anastomosis being done with the vicryl by placing interrupted ligatures. The first corner stitch taken on the right extreme by U-stitch. The anastomosis common bile duct to the jejunum is done in single layer, and the posterior anastomosis is being done by interrupted ligatures starting from right to left. Now reaching the left extreme, finally the left corner stitch is again taken from out in, then from in to out, so that the corner tying will give a secure anastomosis. Both the corners are U-stitches taken for effective approximation of the common bile duct to the jejunum. The anterior anastomosis is again done with the interrupted vicryl stitches. We use conventional vicryl stitches, curved needle, and one stitch multiple ligatures can be taken. Second, another anastomosis, the final anastomosis comes between the end of pancreas to the jejunum, is the Duncan technique, and we take the first cranial stitches, then come down by interrupted vicryl stitches. We here use the thin vicryl from the edge of the pancreas to the full thickness layer of the jejunum. Care is taken by placing the adequate number of stitches which closely pack to prevent a leak. Then finally the pancreatic stent is placed into the pancreatic duct. Then finally the anterior anastomosis is taken with vicryl. This is the final completion of the pancreato-jejunectomy. Both the pancreatic stent and the feeding tube jejunectomy is brought to separate stab, and this is final. Fifth postoperative day, the lady carrying both the bags, drainage from the jejunum and the pancreatic duct comfortably by herself without much pain. and she's able to walk, able to take normal diet, and she is very comfortable after all this major surgery.